This is a case of posterior polar cataract in a young patient which is soft. You can see the circular plaque with concentric rings typically described as having bullseye or onion peel appearance. We need to take all precautions to prevent the occurrence of a posterior capsule dehiscence, which is up to 36% in some reports. Though the pupil did not dilate initially, it dilated reasonably well with intracameral adrenaline. Anterior chamber is filled with dispersive OVD. Care is taken not to overinflate the chamber. The capsular rhexis should be around 4.5 to 5 mm. If the rhexis is too small, it may become difficult to get the soft nucleus out of the bag, and if it is too large, it may become difficult to capture the optic of a sulcus placed intraocular lens in the event of an untoward posterior capsule rent. Hydrodissection is contraindicated in posterior polar cataract. Here I am doing a hydro-free dissection of the anterior cortex from the capsule using an iris spatula. No nucleus rotation is attempted. Phaco emulsification using low parameters, that is low infusion pressure and flow rate, is the key in the strategy of posterior polar cataract. A deep narrow trench is made, thinking I could separate the nucleus into two pieces, but since the cataract is too soft, I could not. Using a Sinskey hook, the nucleus is split into smaller pieces, brought to the anterior chamber, and then aspirated in a controlled manner. Maintenance of chamber stability, avoidance of sudden chamber fluctuations, and use of low Phaco parameters are crucial during the entire procedure. OVD is injected before taking out the Phaco probe to prevent sudden collapse of the chamber. Then viscodissection of the remaining subincisional nuclear and epinuclear plate along with the plaque is carried out by injecting OVD into the capsular fornix, which is brought into the anterior chamber and aspirated. While inserting Phaco probe into the chamber already filled with OVD, where posterior capsule can be fragile, infusion pressure needs to be reduced to prevent PC blowout. Once the nucleus is out, you can see the void corresponding to the area of discoid opacity. Using bimanual INT, cortex is aspirated from the periphery to the center. Before switching hands, OVD is injected again. You can see a ring of opacity on the posterior capsule around the area of the plaque. No attempt is done to polish this, as this area can be weak and polishing can lead to giveaway of the capsule. Capsular bag is filled with OVD and a single piece foldable lens is placed in the bag. OVD is carefully removed, the side spot hydrated gently without producing a sudden gush of fluid wave beneath the IOL. In posterior polar cataract, PC rent can occur at any stage and you need to be careful throughout. We should also have a backup 3-piece IOL in all cases for sulcus implantation in the event of a PC dehiscence. If done carefully, you can reduce the incidence of PCR in majority of cases.